Hello and welcome to the first installment of the Health Storytelling Author Q&A series for this academic year, fall 2024 and spring 2025. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University. I'm the curator of this series, which makes me your host as we undertake our latest set of author conversations. In a moment, I'll introduce you to my guest, Emory Associate Professor Rachel Hall-Clifford, and her amazing new book, Underbelly: Childhood Diarrhea and the Hidden Local Realities of Global Health. But first, let me tell you a bit about this series. At least once per month during the academic year, we invite authors whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations is sponsored by the Emory Center for the Study of Human Health, along with an array of fantastic co-sponsors. This autumn, those co-sponsors are, first, the Georgia Center for the Book, our first supporter, a local affiliate of the Library of Congress that stages very frequent public conversations with authors, illustrators, poets, and others to bring the news of new books to the public. Then also Science Gallery Atlanta, which presents exhibits that ignite creativity and discovery where science and art collide. Their new exhibit, Resilient Earth, opens this weekend. And I'm pleased to announce new co-sponsors for us in this series this year. Emory's Center for Public Scholarship and Engagement, which creates opportunities for faculty, staff, and students to share ideas with local and global audiences, and the center's inaugural Ideas Festival Emory, which will take place from 20 to 22 September on Emory's Oxford campus. Now, let me tell you who else will be appearing in this series, which is live streamed on YouTube, LinkedIn, Facebook, and Instagram, and archived on YouTube. The authors appearing this semester are tonight, Rachel Hall-Clifford, PhD, with Underbelly: Childhood Diarrhea and the Hidden Local Realities of Global Health, which was published by the MIT Press in May. On October 9th, we'll talk to Lynn Peoples and her brand new book, The Inner Clock: Living in Sync with Our Circadian Rhythms, which will be published by Riverhead Books in September. And on November 13th, we'll hear from Lena Zeldovich, who will talk about the history of bacteriophages in her fascinating book, The Living Medicine: How a Life-Saving Cure Was Nearly Lost and Why It Will Rescue Us When Antibiotics Fail, which will come out from St. Martin's Press in October. One final note: this is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, please comment on any of the platforms where you're watching, and our producer, Stefan Kaplan of Spin It Social, will make sure we see what you've said. Do note that I'll turn to your questions in the second half of this 60-minute live stream, but you can put your questions in at any time and I will catch up to them. So now let's turn to our book and our guest. Rachel Hall-Clifford is an associate professor in Emory's Center for the Study of Human Health, and also the university's departments of Sociology and Global Health. She's a medical anthropologist who has held research positions at Harvard, Oxford, and the London School of Hygiene and Tropical Medicine. She applies social science approaches to global health research and implementation, and she's conducted fieldwork in the central highlands of Guatemala on the delivery of health services for more than 15 years. Rachel, I am so happy to be doing this. It's really a thrill to talk to you, and I cannot wait to talk about poop.
Thank you so much for having me on. I am excited for this conversation.
So I just told people sort of who you are and what your title is, but I think we should start by hearing a little bit more from you about your work and your professional practice.
Absolutely. So, as you mentioned, I'm a medical anthropologist. And since anthropologists tend to study human behaviors, beliefs, ideas, and living patterns, I do that, but for health. And so, I have always been interested in sort of cross cultural practice and the ways that people interpret symptoms of health, experiences of health, and health seeking differently. And so that led me into a career in medical anthropology and then into applied global health work. So I kind of feel myself bridging those two worlds between the sort of more liberal arts study of medical anthropology with the day-to-day work that needs to happen on the ground for global health.
So, we get a really wide array of people in our audiences on this series. And so I think for the benefit of folks who are not within the academy or within your discipline, maybe say a little bit more about what anthropologists do.
Yes, absolutely. So, the hallmark of anthropology is really ethnography, and ethnographies are produced by living and ideally becoming a part of the community that you set out to study initially. And so, anthropologists are known for spending 1, 2, or many more years in a location, living and working. And that's how we kind of produce knowledge and begin to understand the realities of that local place. I, as you mentioned, have spent a lot of my time over the last nearly 20 years now in Guatemala. And while I can never be from there, I am so happy to have it as a second home and have built the kind of long-term relationships that are both so fruitful as an individual human, but also give very deep insight into local patterns and beliefs and kind of what's happening. And that really is what enables the kind of work that I do.
So I want to get to a minute. I'm going to loop back around to this question of deeply embedding in a place for a long time. But I'd really like to know first, why Guatemala? And maybe you could tell the audience a little bit about sort of the immediate past history of Guatemala, which is quite complicated.
Yes, absolutely. So I was interested in a very particular type of public health campaign that is targeting childhood diarrheal disease, which we will talk more about here. And I wanted to be able to live and work in a place that had had that type of global health programming for as long as possible. And I knew that I wanted to work in Latin America. And so I sent out feelers to a lot of different sites and different organizations to explore potential partnership. A couple sites in Mexico, one in Costa Rica, one in Guatemala, and so on and so forth. And I did some initial visits, and things just really clicked in Guatemala. The contacts that I made were very eager to have the research. They felt like it was needed and they wanted to partner. And so that was a real, kind of boost to the work. Also, my best friend from graduate school is from Guatemala City. And I've been so lucky that her family became, my family in Guatemala. And so, the stars just sort of aligned for me to begin my work there. But it's also the kind of place that just really pulls you in. And, I've kind of never left since I first went in 2005. I think you mentioned, though, the troubled kind of history of Guatemala, and it is just the most beautiful place that you can imagine. It reminds me in some ways of my home in East Tennessee, where I grew up, although the mountains become volcanoes instead of the Smokies. So you've got this very lush, beautiful countryside. You've got lowland areas, a rainforest. It's just really rich in natural resources and culture and beauty. But it has incredibly entrenched racism and a very long history of ethnic violence. So we had a 36-year civil war in Guatemala that only kind of officially ended in 1996. So that context is still very much alive in people's memories. And we had a lot of government repression of the indigenous population during that time. All external bodies have identified that as a genocide, but that label is still very contentious internally in Guatemala. And so it's within that context that I was considering health and the rebuilding of health systems, after a genocide.
So you're coming into this country that that has had all this difficulty, as you say, that has what seems from your description to be extremes of socioeconomic status, and you're coming in as a white appearing woman from a country that's understood to be affluent. And I'm really curious, as a journalist, someone who also like tries to embed in places for long periods of time, I'm really curious how you navigate appearing privileged and how you literally negotiate being able to move into households and live among them and figure out how that appearance of affluence works.
Yeah, that's such a great question. And it's, incredibly challenging. I'm always aware that, I'm a nice white lady from Tennessee. I have all of these incredible privileges that attach and that come with me. And, how to kind of engage with people in a genuine way that, doesn't feel like, oh, I'm compelling, oh, sure, you can stay with me or whatever. So I always adopt what I call a nested ethnographic approach, which is that I basically network. So I started my my very initial fieldwork living in the city of Chimaltenango, which is a very large city in Guatemala. And I was attached to a nonprofit clinic. And so in doing so, that created a network. I lived with a member of their staff initially. And so that became kind of a primary family. And that really helped. So I spent several months living there and kind of working, building my network. And then after that initial move, I've only kind of moved in with someone in my network. So, there's always someone who has an aunt who lives where I need to go. And so I kind of use that as, frankly, a literal safety net to make sure that I'm making good choices in terms of personal safety, but also that, I'm with people that kind of understand and recognize the project that I'm working on and, that they want to contribute as well.
So this is the time to start talking about the projects. I'm still going to remind people, I know there are plenty of you listening. I can see those numbers ticking up. If you have any questions that you'd like Rachel to answer in the second half of this program from about 7:30, please put them in a comment or put them in the box at any time, and we will get to them. We would love to hear what you're curious about and what your reflections are about what she's saying. All right, you promised me we were going to talk about poop. So I am very curious to know why you decided to focus on childhood diarrhea. And I think here we need a little context for the viewing audience, because probably most of us as privileged, developed worlders think of diarrhea as something that just kind of casually happens to kids once in a while, and it's difficult for a day or two, but then they get over it. But what you are talking about is happening in a profoundly different context. And I'd like to hear you explain how it is that childhood diarrhea is actually a profound health problem worldwide.
Yeah. I think you nailed it right there, that it is diarrheal disease. Seems like, oh, no big deal. And also I get a lot of kind of funny looks and questions, especially at, like cocktail parties and things like that when I say what I do. But diarrheal disease is actually the third leading cause of death of children under 5 globally. So it's this massive global health problem that is really kind of under addressed and under discussed. Children in the US experience, on average, 1 bout of diarrheal disease per year. And it's usually exactly what you describe, an unpleasant couple of days. You give them some Pedialyte or something and, you move on. In Guatemala, that average child under 5 experiences 10 bouts of diarrhea every year. And so what this does is really locks them into a cycle of undernutrition, that impacts lots of other elements of their growth and well-being, and ultimately for many, unfortunately, for survivorship. So, children who are undernourished are more vulnerable to infection. They become reinfected. That, further decreases their nutritional status. And so they kind of get locked in this cycle, unfortunately.
So right from the start in the book, you introduce this somewhat solution to the problem of global diarrhea, which is oral rehydration therapy or an oral rehydration solution. That seems like it's a simple answer to the problem, right? Kids are losing fluid from their bodies. You replace the fluid, but you explain very thoroughly and in a way that's really fascinating to me and that I hadn't thought about, the way in which that sort of acute answer to what's really a chronic problem really hasn't solved this health burden globally.
Yes, exactly. So oral rehydration therapy can keep a child alive through a bout of diarrheal disease. It's familiar to us, things like Pedialyte or, giving electrolyte solutions is often what, we do as well. There are particular formulas that have been optimized, et cetera, but they can be really anything that is locally available. Mixing a little bit of sugar and salt together is just fine. Using the water that's um, in a pot of boiling plantains or rice, also just fine. So just that kind of electrolyte solution can really help a child survive. And when oral rehydration therapy was first created, it was seen as a solution to keep people out of hospital, especially during outbreaks of cholera, which we're unfortunately seeing around the globe right now as well. But it doesn't solve this systemic problem. The kids are still getting frequently exposed to diarrheal disease. It's kind of like a Band-Aid on a very broken infrastructure. So within Guatemala, unfortunately, there are not safe municipal drinking water supplies, and there are also not sanitation and sewerage that cover the country. And there are huge disparities between urban areas and underserved rural areas, which are also mostly populated by indigenous Maya communities. And so you kind of start to get that patterning of it's the social exclusion from public services and public goods like health services and water infrastructure and sanitation that really continues to marginalize the Maya population.
So if I understand correctly, oral rehydration therapy has been around for quite a long time. And when it was first sort of formalized decades ago, it changed a lot of the provision of global health for children. And so it's really interesting to hear you say that that though this therapy for an acute moment of the problem continues to be successful, the feeling I'm getting from you is that the infrastructure, not just within the country of Guatemala, but also the infrastructure of global health broadly, isn't really working the way it was intended to. It isn't backing up the effect of this therapy with any kind of ongoing structure. Maybe I'm characterizing this, but I'd love to hear you talk a bit more about how global health writ large it is or isn't working.
Yeah, I mean, this is such a huge question, and it's a challenge that, I try to trace in the book because I think we have such a disjuncture between the really big structures of global public health. Many of us think to like the World Health Organization in Geneva or the Gates Foundation in Seattle, these really big organizations that fund and power a lot of our agendas in global health, but they're, of course, located in the global north and very far from the realities of day-to-day life in local communities like where I've lived and worked in Guatemala. And so I think that, there's the road to hell being paved with good intentions kind of dynamic that happens here, especially when we're looking at childhood diarrheal disease. There have been huge, programs and, funding pushes to help alleviate this problem, but the decisions are largely being made very far from communities where those programs play out. And I think that there's a huge disjuncture there, not just sort of, in terms of culture, but in terms of what's really needed. What are the priorities? How can we kind of stop this cycle of childhood diarrheal disease that I was describing? And I think we have a really long, way to go in that regard.
So later in this hour, I do want to talk about this concept of bringing the decision making closer to the people who are experiencing the problems, because that's a very, very exciting thing. But let's talk about a little more of the bad stuff first. So as I've traveled in low and middle income countries as a journalist, you very quickly run into sort of the detritus of past global health, public health programs, things that maybe were brought in by donors or by organizations and then were quickly repurposed because they didn't serve the local need, or because the program ended, because funding ran out or funders' priorities changed. And I wonder how that phenomenon of things not necessarily being funded or thought through for the long term affects what you're talking about.
It's such a huge problem. And I think it's one of the biggest issues facing kind of sustainable change in global health. One rural community that I'm thinking of where I've lived for quite some time, you look all around and it's truly this graveyard of global health interventions where there's a USAID latrine that's being used as kind of a shower stall. And, you see all of the things. One example that comes to mind of like the real problem that causes is that within this community, one of my friends, we were sitting on her patio, kind of doing some afternoon work one day, and somehow the subject came up, and she said, Rachel, there's no proven way to purify water. And I thought, she is a very like a smart, thoughtful, kind of introspective person. So I was like, okay, tell me more about this. You're not just shooting from the hip here. And she said, well, in the last 2 years, 3 different global health groups, she didn't call them global health groups, 3 different groups have come in and taught us about water purification. One was a group of gringos that told us to put water in like clear plastic bottles and put them on the roof of our house. And she was dying laughing because Maya women are often very short in stature and she could not reach her roof, nor could I. And then there was another group of from a large multilateral aid organization that had provided bleach for putting drops in the water. And of course, if anybody has ever swallowed pool water, you know that tastes gross. And then finally, a government group had come through to do education and taught everyone to boil their water. And, an issue there is that firewood is costly either in time or in money to buy it. And so that poses really significant challenges. So there's kind of drawbacks to each of these methods, but also each of these programs had come in completely unaware that others had been in this incredibly remote community already. And so her very rational conclusion from this was like, well, there's all of these different suggestions, but no one proven way. And
none of them work.
So none of them really work. And, so I think that's really, example of how uncoordinated work, assuming that we're coming into sort of a blank slate in global health programming, can cause actual harm.
So one of the folks who's watching asks, is it hard to get funding for the particular issue that you're working on, poop, childhood diarrhea, because it's unglamorous? Has that been a problem?
Yes, absolutely. When I first started out in graduate school, I was told that my work was very old-fashioned and that no one cared about diarrhea anymore. And I was like, well, but these mortality and morbidity tables would say otherwise to me. But, I think that it's been sort of an uphill battle to really increase kind of awareness. I think in the last few years, I'm seeing further movement from like big picture global health structures to focus once again on diarrheal disease. And so I remain, hopeful. But I also think that that points to the problem of global health, that there are trends of kind of what's hot now. And those things attract funding, and other, omnipresent problems are still there. They're still persisting.
This is probably going to sound like an unfair caricature, but I feel like I need to ask the question. I think when people who are not familiar with the area think of big government programs in Central America, they are going to wonder whether they are affected by corruption and whether part of the funding problem is that things are being siphoned off. Is that a reasonable fear? Is that something that the programs that you're talking about have had to deal with?
I think that there is definitely some truth to that reality of corruption and to things going astray in Guatemala. I have a colleague who I think very highly of in a very admirable global health organization. And I was trying to convince them to kind of do more programming in Guatemala and thus like bring in more resources. And he looked at me and said, Rachel, Guatemala is a development dump. We will not be doing programming there. And I was like, man. And, he kind of further described like money just pours in, but nothing really changes. And it's been a while, maybe 10 years or so since this conversation. And I can kind of understand this perspective. I myself was doing a project, it's been a few years ago now, on zinc supplementation to help in bouts of childhood diarrheal disease. There was a lot of energy and enthusiasm. The World Health Organization had updated their sort of guidelines for oral rehydration to include zinc. And a large Canadian NGO had donated millions of doses of zinc to Guatemala. And so I thought, this is really an opportunity to see, what we can do to measure the acceptability and the uptake of zinc in communities. Unfortunately, for the entire 2-year study period, there was never any zinc in the community. So this like field study of zinc implementation for WHO guidelines, like was kind of dead in the water in terms of actually understanding the use of zinc. And I realized I kept asking, well, where's the zinc? And I kind of moved up from the very local tier of the health post through the health kind of ministry. And then I realized there was a regional health leader who was siphoning off the zinc, and it was going into the private marketplace for sale. So that was incredibly frustrating, incredibly disappointing. They really, really did not want the gringo to keep asking questions about it, as you can imagine. And so I think that, that element really also poses challenges for attracting new funding, but also for rebuilding the faith of communities, of local populations, that, their government will do what it says it will and actually deliver services to them. So it's a big challenge.
So one more thing that I want to ask about sort of the underlying problems here, and then we'll get to some of the solutions, is almost all of the characters in this fantastic book are women, and they're women existing in a society that's still quite patriarchal, quite gendered, and they're the particular women that you are studying and living along and alongside and trying to understand are women who have been they're suffering from sort of several layers of oppression, not just being women in a patriarchal society, but being Indigenous, suffering from colorism, suffering from poverty. And I would love to hear you talk about these women and about their position in society and about all the work they seem to be doing, both not just work for their families, but sort of the unsung work, the uncompensated work of global health to make some interventions work?
Absolutely. I think, global health is led by men, but delivered by women.
Mm.
And ultimately, we really see that in the Guatemalan communities where I've gotten to spend time. When you think about these incredible asks that we're making of women in communities to do something different, to take on extra labor, to, yes, ideally to help the health of their children, but it's all put on their shoulders. In the trainings that are given within communities for children's health, it's just kind of seen as de facto that women are the caregivers for children.
Mm.
But also in terms of health seeking, it's primarily women who are doing that. And that leaves other challenges for men's health, which are very important too. But the sort of power dynamic between providers or global health promoters that are out in communities, not always, but is very often incredibly asymmetric, and they're talked down to. And so the women are sent to participate in those programs because the men wouldn't accept that. And so I think that we get a dynamic of often non-Indigenous men or non-Indigenous field workers delivering services to Indigenous women. And, they're kind of in a position of having to just sort of take what they can get. And they're told to do things like, please give your child this oral rehydration every 20 minutes is the recommendation during a bout of diarrheal disease. Well, if you have 7 other children and a field that you're tending and you're cooking and doing laundry in your home, that's an incredible burden. And then the decision if a child continues to be unwell and needs to go for further, health care within a health facility, the blame is often put on mothers, like, oh, why didn't you bring your child in earlier? They're very sick now. But it's really not the women who are kind of free to make choices about traveling, potentially catching transportation, spending money on that transportation. And they have additional burdens often of, who will care for their kids who will remain at home, et cetera. So there's a lot of dynamics of needing to ask the mother-in-law, to ask the father of the family for permission to do these things, which external groups have told her she should be doing to be a good mother. So I think that, there's a lot of additional burden that's placed on women on kind of what it means to be a good mother, particularly in terms of diarrheal disease. It's kind of seen as, I guess, stigmatizing if your child gets diarrhea, because it's like, well, you're not a good mother. You didn't, keep them clean. You didn't keep your household clean. So that really introduces this, really challenging element for care seeking, even though all of the environmental odds are just stacked against them.
So it just happens that someone who's watching this just asked in the chat, how do you stigmatize conversations around diarrheal disease?
Wow. So I spoke a little bit earlier about the incredible, privileges that attach and carry with me. And I think that I also use that privilege to be the sort of, wacky outsider who brings up taboo things. And so I know a lot of ways to introduce diarrheal disease into conversation, I guess, is for better and for worse. My husband might be like, oh no. So I think just continuing to talk about it. I also see a lot of interesting destigmatizing strategies locally, which are to kind of distance oneself from a bout of childhood diarrheal disease. For example, there are set milestones in a child's life when it's just expected that they would have diarrhea, particularly when teething or weaning.
Hmm.
There's also some seasonal patterns to diarrheal disease, which actually it's very interesting. They map to when we know viruses are more active. So the rainy season tends to have more diarrheal disease, and people talk about that. But if your child gets diarrhea outside of those kind of expected times, it's a really common strategy to say, oh, these kids, they pick up things in the street, or you must have gotten snacks out of the household and things like that, to kind of say that makes it more socially acceptable, if you will, to say like, it wasn't from here.
So we've been talking so much because so much of your book is about exploring this problem. So I really want to get to the solutions piece. We referred a little bit when I was introducing you to your being one of the leaders of the co-design lab at Emory, but I don't think people are going to know what that means. So what I'd like to hear you talk about is just this question of how do you bring the decision-making closer to the people who actually need the interventions? How do you involve them and break them free from this kind of oppressive global infrastructure that you've been talking about?
Yeah, so the co-design approach is a community-centered approach where I do not sit in my office here at Emory University and think of ideas or think of problems to solve, but I really listen and work with local communities for them to identify priority problems, and then we work together to facilitate solutions. So in the case of the co-design lab, that often involves low-cost technology, like you see here in a design workshop. Not always, but it's very exciting, the kinds of technologies that we have access to that are low cost, that can harness the power of AI to really democratize healthcare and bring cutting edge resources to the local level.
I think we need an explanation, not an explanation. We need an example.
Yeah. So, for example, the picture that you just saw for a moment there, we're doing a design workshop to redesign hardware for a long running maternal health project that's called Safe Natal. And Safe Natal was really led by Indigenous Maya midwives who have no formal biomedical training, but are traditional birth attendants. But there's a very strong cultural preference for giving birth in the home in rural communities. And Indigenous women also face a lot of kind of barriers and racism when they seek care within health facilities. And so we wanted to um, respect that cultural tradition and enable women to give birth at home with their midwives when it was safe to do so, but to identify as early as possible complications within pregnancies and during birth so that they could be referred to facility-based care in a timely manner. And so we worked with the midwives to design the technology, design the toolkit. So they now have an entirely pictogram-driven app, which they can scroll through. They designed it themselves. Many of our midwives are not literate, and several had not used a smartphone prior to the start of this project. And so they're really able to have, access to this technology and to refer their patients when complications are detected. So it's been very exciting. We've seen really important reductions in maternal mortality and morbidity. And so we hope to continue to grow that work. But that's an example where we really just work together. I don't see myself as, a problem solver. I'm a facilitator to try to bring together solutions when they're identified by communities.
So how are you bringing this local decision-making co-design approach to this problem of diarrheal disease that we've been talking about?
Yes. So several approaches. The kinds of water sanitation and hygiene trainings that are delivered in communities can and should be made better. And so I've done several projects over the years to make sure that local voices are leading those and that they make sense for the local context. I had a project, it's been several years ago now, where a North American clinical colleague was very insistent that we include chicken broth as an oral rehydration solution. And everyone was rejecting the chicken broth in Guatemala because it doesn't fit with their kind of cultural notions of what would be healing for a sick child with diarrheal disease.
Mhm.
And so, I just pushed back and said, we're not doing that. We're doing what they want and what they identify with. And so there can be really simple things. And there were lots of oral rehydration solutions that people did identify locally that were culturally appropriate. So that's easy to do. I'm also working on a project that is to improve local water quality testing. And this project is being run in collaboration with Ecofiltro, a Guatemalan social enterprise that distributes water filters, as well as a microbiology lab at the Universidad del Valle, Guatemala. So it's been very exciting to try to work towards this goal. And I really hope that it empowers communities to be able to, test their water, identify that it has E. coli, take measures for drinking water in the meantime, but also to put further pressure on the government to make sure that everyone has access to clean water.
I want to turn to some of the questions that the audience has been asking. The first is about the pressure of social media. And I think we can probably broaden that to the pressure of sort of informal informational networks in the context that you're working in. You're trying to bring culturally appropriate but validated medical and public health knowledge. Do you find that there's a pushback to that, or counter narratives that you have to sort of intercept and mediate, so that incorrect information, whether it's mis or disinformation, doesn't sort of get in the way?
Yes. Just like here in the United States, ideas circulate, gossip kind of takes off and takes on a life of its own. And I think, now more than ever, we're in an interconnected universe. You can Facebook in Quetzal, one of the local Maya languages. And so people are like, the speed at which that circulation of information, which I think was absolutely always there, has definitely heightened. In fact, it was really kind of heartbreaking and interesting to see during the COVID-19 pandemic, when I, spent, I think, more than a year actually not in Guatemala at all, but was hearing from friends on WhatsApp and other social media channels in Guatemala. And the questions that I was getting about, hey, what do you think about COVID-19? What should we do? Kinds of questions. I could trace the sort of life cycle of misinformation from the US, and then a bit of lag time, and then it would kind of percolate into very rural Maya communities in Guatemala. And so I think that, we're part of a global network, and I think that global public health has to step up our game in terms of sharing accurate and valid information. For my part, I do absolutely what I can for the networks that I'm a part of to share information. Myself, I'm trained in public health, but I'm not a clinician. So I'm always trying to refer to good sources of care, to good sources of information. And I'm incredibly excited that there are some Guatemalan public health advocates and leaders that have built an app and some social media channels for good health information that are becoming more widely used. And so I have hope that, people will see the value of tapping into those high quality sources.
This is a good time to ask another question that's just come in from the audience. What are some things that people forget to consider when facilitating the kind of collaborations you're talking about between big global health organizations and local community ones?
Yeah, I think it's that the biggest thing is that you can't anticipate where things are going to go. And for co-design to actually work as a global health model and for it to be scalable, I think this is one of the biggest challenges because it doesn't fit into the tidy boxes of, grant applications and funding structures that we all typically live and breathe by in the field. And this is because if you're really going to set the local collaborators in the driver's seat, you have to let them drive. You can't just say, oh, we're going to partner with you, but then do whatever idea you wanted anyway. You have to really let them choose and let them lead. And so, sometimes it goes in surprising directions. I came to the conclusion that I would only work on co-designed projects. It's been many years ago now, but I had gotten some funding from a U.S. Government source, and I was very excited to be doing some research. And we had kind of the local Indigenous Town Council agree to the project. But then as we were kind of talking about details and, this is what we're actually going to do on the ground, they were like, is that what you want to do? Because we'd rather you just use that money to bring in medications. And I thought, well, I see your point. Unfortunately, my funds were totally restricted and we had to do what we said we were going to do. But that's the last project that I've done that was like that didn't have from the very front end, local leadership or local guidance of what we were going to do. Because otherwise, I think that you do get, these really unpredictable outcomes with a global health program coming in from the outside and people either rejecting it or using the resources for something that, wasn't really intended.
Another person who is watching us asks, is there anything that an average person, someone who's outside the public health infrastructure, outside healthcare, is there anything that they can do to support this work?
I think becoming an informed global health citizen is so important for all of us. Sometimes particularly Americans get a sort of knee-jerk reaction of why are we spending all of this money abroad when we have so much need here? Absolutely. Global health is here in our backyards as well. But also being informed about, our interconnectedness as a globe of humans is so important and vital to this work. I think many of us lived through this and, are living through this with the COVID-19 pandemic and seeing the interconnectedness of humans. And so I think that global health is not a sort of niche activity, but it's something that we're all a part of.
So let me ask you the last question. We're running out of time. But I'd love to hear sort of what's next for you or what you're excited about in this co-design approach or in projects that you're looking forward to. We talked about so many problems of corruption, of racism, of patriarchy, of sort of developed world to developing world, imbalances of power. Where are the sparks of hope for you?
Absolutely. I am excited that we have a very hopeful new presidential administration in Guatemala, and I fully expect really wonderful improvements in the way that government is run, as well as within the Ministry of Health. And so I have a lot of hope there. The Safe Natal project that I mentioned for maternal care is set to grow. We have some really nice external funding that is going to help us really do that. And in fact, we have a lot of good peer-to-peer learning that is taking the innovation from Guatemala and seeding pilots in Ethiopia, Rwanda, Sierra Leone, and lots of other places. So that's very exciting. And then for me, I'm going to continue thinking about how can we make co-design a part of the DNA of global health? Can we scale it up? And so I think that that's my next big project.
It feels like this is the perfect time for this. I think that the COVID pandemic, as much as we all want to think that it's over, showed us, I think, the degree to which it made visible to us inequalities in public health around the world. And the way that you're proposing a fresh way of approaching those inequalities through the lens of local communities, it just seems so essential.
It also seems so obvious to me, Maryn, but I'm hopeful that co-design becomes a real thing, not just another buzzword or thing that we say. I'm kind of hopeful. I'm seeing more use of the term co-design within the global health kind of conversation in the last 2 or 3 years. But, I think that we're a field driven by what's new. And once something's not new anymore, the money and the interest tends to move on. And so I hope to really harness this period of kind of interest and enthusiasm for co-design and for low cost technologies to really try to embed it within to kind of our processes and, how we do things in global health.
I hope that comes to pass. Rachel, thank you so much for talking to us about your projects and about this fantastic book. I really appreciate your launching our series this semester with this incredibly thoughtful examination of both the problems and also the promise of where global health might reform itself. So that is it for the first edition of the Health Storytelling Author Q&A series for this fall. Please consider following Rachel on social media. Her Twitter or X address is R.A. Hall-Clifford, and she's Rachel Hall-Clifford on Instagram. And buy her book. It's available at her publisher, the MIT Press, and at Amazon, of course. And it's also available at bookshop.org, which is kind of the anti-Amazon. It's a platform that funnels orders to independent bookstores, which we love. Please join us next month on the 9th of October to hear from Lynn Peoples and her brand new book, The Inner Clock, Living in Sync with Our Circadian Rhythms. And also join us on the 13th of November when Lena Zeldovich will discuss the work she performed in Russian and Georgian archives in those languages to write the history of bacteriophages, The Living Medicine, how a life-saving cure was nearly lost and why it will rescue us when antibiotics fail. Until those, I'm Maryn McKenna, on behalf of the Center for the Study of Human Health at Emory University and our co-sponsors, the Georgia Center for the Book, Science Gallery Atlanta, Emory's Center for Public Scholarship and Engagement, and Ideas Festival Emory, and from me, thank you for watching. See you next month.